What are the main things, Sonia, that doctors from other countries need to understand about the doctor-patient relationship here in Australia?
So I think the main things that we found over the past few years is while working in Australian sort of culture with medicine is the big differences between the hierarchy. So there's a sort of a boss or a god culture where the doctors put up in a pedestal still in developing countries. And here it's power sharing, there's a team approach and everybody has their say. So we've sometimes there may be an issue with communicating with the other team members, especially with the allied health and with the nursing staff, where we feel that it might not be that they might not have an equal say, but they do. They're an important part of the team and they need to have equal say as well because they act as patient advocates. Sometimes the doctors, the IMGs might feel if the nurses are pointing something out or suggesting something, the IMGs might feel or the doctors might feel that their authority is being challenged, but that's not how it's taken here. It's what the culture is, and it's everybody's got a right to their opinions. Everybody's expertise is welcomed and taken into consideration. Next slide, please.
Next slide, please.
And again, sometimes expressing opinions could be taken as a defensive or confrontation, whereas that's not the intention. It's just stating an opinion and stating it as it is. So next slide, please. So the other thing that we need to be mindful about is often some of the doctors, and I'm not just generalizing, some of the doctors come from a culture where the male children or the males of the society are given a higher status as compared to the females. And often the females are expected to be submissive, be a home carer or nurturer for the family. And often that might be a bit more, confronting for the doctors coming from such a culture, where they might find it a bit difficult to work with women or in other roles as their team leaders or in a superior sort of hierarchy than themselves. And that's where sometimes that there might be some culture clashes there. So some of the female doctors might find that they are actually working at home, doing all the roles as a housewife, as a parent, looking after the family and the home, and also working full-time as a doctor here in Australia. And that causes a little bit of stress and overwork for those female doctors as well. Okay, next slide, please. So in short, communication is between the GP, the relatives of the patient themselves, the important part of the conversation, the colleagues and specialists and nursing and allied health. They all work together as a team. So you're not working on your own, you're working together as a team. And that's something that's very typical of, working in Australia as a doctor. So you're very well supported. You have lots of support, from different sort of allied health, nursing staff, giving you their inputs, the colleagues and specialists. Everybody is really supportive and very helpful if you have any queries or if you need any help with the patient management. Yep.
Absolutely. Madan, can you tell us a little bit more about this concept of the GP being the cornerstone of the patient care and sort of knowing a lot about their life and are there any kind of pitfalls around that sometimes, around boundaries and other things?
The main thing, as a family physician or as a general practitioner, the relationship like what we develop like with the patient, because you tend to not only the medical issues, like we tend to explore the psychosocial aspects of the patient. And again, like a lot of times, like the general practitioner will be in a better position to assess the like whether any particular intervention or like anything, is it like suitable for the patient's circumstance or not. And frequently we do come across situations wherein I have come across patients telling the specialist might wanted to do a particular investigation or like start them on a medication. Lot of times the patients tell the specialist like, I see you only once in 6 months. Probably like my GP would know, like better. I'll check with my GP and then probably like I'll start the medication. And obviously because the financial side of things and there are like and the pros and cons. Say for example, the person might be the sole breadwinner for the family, and this person might have had like advanced osteoarthritis like in the knee. And even though the best course of action as a practitioner, I would think that he needs to get like a knee replacement. But if he's going to get into the hospital and if he's going to stay in the hospital for rehabilitation and 6 to 8 weeks, who's going to support the family? And the GP is the one like who's going to help him to navigate through the necessary supports like what they require. And again, as Sonia pointed out, like the multidisciplinary team approach, because we frequently we tend to think that like that the whole responsibility is on us regarding the patient management, whereas like here we tend to share the responsibility. Say for example, like I still remember like one of my colleague like who wanted to do a CT of the knee, and straight away the radiologist gave him a call. Probably like in this particular situation, like a CT may not be an ideal option. Probably like he would need like an MRI. But this colleague, like he took it like personally and he started arguing like probably like, I know the patient, like I want this. But completely the point missed was like, it is in the best interest of the patient. It is not like frequently do get like calls from like an echocardiographer or a sonologist trying to get the clinical information. Likewise, if I have like any query, like I always like I find it easy to give a call and find out, like, because at the end of the day the center is the patient's welfare. So there is no power imbalance between the different team members. Like all of us, like we tend to play an essential role in the ultimate like management of the patient. And that is what like I learned a lot. It is not just the medical care, it is how we assess, how we deliver the care in conjunction with all the clinical and non-clinical staff, like how we involve them to deliver the best care for the individual. Thank you.
Yeah, when we were discussing this in preparation, we talked about that shared decision-making model, which also includes the patient. It does create a bit of tension because there's perhaps a question coming through. There was a comment in the chat about doesn't the buck stop with the doctor still? It does, but you make much better decisions as part of a team than you do in isolation as well, and especially if the patient is and their family are in alignment with you as well.